So we are going to go ahead and get started. Again, welcome everybody. My name is Elizabeth Aloni and I'm with Schneps Media. Schneps Media is the largest local media company in Metro New York. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events. And we do so throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, and Philadelphia. Today, we're thrilled to bring you a very important topic, dementia care, understanding care options and proactive planning. Cognitive decline or receiving a diagnosis of Alzheimer's is usually not something we plan for in retirement. Unfortunately, it's a reality for many families. So what now? Today we have with us Julie Wexler, MPA, who will guide you through understanding this disease progression, how to deal with the day-to-day challenges of caring for a loved one with dementia, and what care options are available to ensure the best quality of life for all. We will also hear from Aaron Futterman, who's a CPA and an attorney, and he will discuss the importance of expertly written advance directives and what families can do right now to ensure access to the best possible care in the future. Let me tell you about our illustrious guests today. Julie Wexler, MPA, has spent her 25-plus-year career in a variety of elder care settings, including community-based senior services and government agencies for the last 8 years in the senior living industry. Her experiences inspire her to develop and support programs to improve the quality of life for all older adults. Julie is an invited speaker on topics related to aging, Alzheimer's and dementia care, caregiving for older adults, and understanding elder care resources. Julie believes all seniors, regardless of cognitive or physical decline, deserve to live a full, active, supportive, meaningful, and purposeful life. That is wonderful. Welcome, Julie.
Thank you. I'm so delighted to be here this morning with all of you.
Perfect. Next, I'd like to introduce you to our other illustrious panelist, who is Aaron Futterman. Aaron Futterman, along with his partner, Ron Lanza, established the law firm of Futterman, Lanza, and Pasculi, which is formerly Futterman and Lanza. Prior to this law firm, Mr. Futterman worked for several years at a premier Long Island elder law and estate planning firm. The legal and tax experience Mr. Futterman has acquired over the course of his career helps him to serve his clients. He has helped many individuals and families plan for their future while alleviating the fears, anxieties, and concerns many families experience when facing the unknown or inevitable. Mr. Futterman's work experience as a certified public accountant with 2 of the world's largest public accounting firms enhances his ability to resolve the complex legal issues that arise in his estate planning, tax, and elder law practice. Welcome, Aaron.
Hi, thank you.
So happy to have
you. A long introduction.
well worth it.
I like brevity.
Everyone needs to know your tremendous background.
Oh, thank you.
So right now I'm going to turn it over to Julie because I would love for her to share with all of you her valuable information. Julie?
Thank you so much, Elizabeth. We're delighted to be here this morning to discuss this very, very important topic. We are going to talk to you today about dementia care. We're going to talk a little bit about what some of the early signs are, how to access care, and equally as important is not only taking care of the loved one that you might be taking care of who has dementia, but also taking care of yourself, taking care of the caregiver, equally as important. So I want to start with talking about what is dementia, right? People sometimes use the phrase dementia and Alzheimer's synonymously, but they're really not the same thing. Dementia really is an umbrella term that is used to describe a group of symptoms. Different disease processes can cause dementia, all right? Some of the things that we see when somebody is described as having dementia is loss of short-term memory, right? So that person who is repeating themselves or is losing language ability, having word-finding problems. Maybe they're having issues with executive functioning. Executive functioning is being able to perform those things that we perform every day that are often in sequential, such as getting dressed or even using the bathroom. Maybe their reasoning. I sometimes say to people that along with the memory, so goes the person's ability to reason, right? Or maybe behavioral changes. We might see depression, we might see paranoia, we might see delusions. Those are some of the things that we see when we describe a person as having dementia. Most commonly, it is an Alzheimer's disease process that is causing the dementia, right? So we know that there's different causes of dementia. Alzheimer's disease is just one cause of the dementia. But you can see here on my slide that there are other disease processes that cause dementia: Lewy body dementia, vascular dementia, frontotemporal dementia, Parkinson's, Huntington's disease, or even a combination of some of these things. I just also want to mention that I am not a doctor or a medical professional. So anything that we're talking about today, please, it does not override any of the advice and medical advice that you're getting from your medical team and your doctors. Just some statistics about dementia. We know that right now, 50 million people worldwide have a diagnosis, including 5 million Americans. And 1 in 3 people in their lifetime will be diagnosed with dementia. The biggest risk factor for having a dementia diagnosis is age. So wonderful that we're all living longer, but unfortunately with that comes the increased chance of having some form of dementia. So at 65, the chances are 1 in 10. And by the time we're 85, the chances of having some form of cognitive decline are 1 in 2. We know that it is the 6th leading cause of death, and we know that it has a tremendous cost to our economy, $305 billion to our nation in 2020, and this will rise to $1.1 trillion by the year 2050. And so why is this happening? This is happening because the population is living longer. And we also have those baby boomers, that surge in the population that are aging as well. So those two things combined are going to lead to more incidences of Alzheimer's and other forms of dementia. The other thing I just want to mention to you is that among people 65 and over, African Americans have the highest prevalence of Alzheimer's disease and related dementia, followed by Hispanics. So there are certainly health disparities in our society, and unfortunately with Alzheimer's disease, their access to care, their access to services, their access to proper diagnosis can also be limited as well because of socioeconomic factors. So when we think of Alzheimer's disease, we think of it as a decline, or dementia. We think of it as a decline from a previous level of functioning, right? It is a progressive disease, okay? So it starts off with early symptoms, and those early symptoms very often can be a clue to what form of dementia it is. And so it's one of the reasons why having an early diagnosis is important. Those early symptoms that you might be seeing, are we seeing short-term memory loss? Are we seeing personality changes? Are there falls? Is there loss of language ability? Are there hallucinations or sleep disturbances? All these little things that we're seeing might be a clue to what form of dementia it is. And you know, it's really interesting. In our world, in the professional world, and particularly in assisted living, to us, it doesn't really matter what the diagnosis is, right? We're gonna treat the person with the symptoms that we're sort of seeing in front of us. But for families, it is so important to be able to put a label on it. And sometimes it's hard to do that. And one of the things we're going to talk about in a few minutes is the importance of finding a doctor who is going to be your partner in that diagnosis process. So we know that dementia is progressive. We know that it's going to start off mild and progress as time goes on. I just want to distinguish it between delirium, right? Sometimes we hear, oh, you know, mom, all of a sudden she's agitated. It was a very rapid change in her personality. That is we want to make sure that we're not missing out on what could be a delirium, which might be caused by a sudden change in health status. Very often in the elderly, for example, something like a urinary tract infection can manifest in behavioral changes, memory problems, language inability. So if there is a rapid change in behavior, don't just think that, oh, this is mom's progression of Alzheimer's or mom's progression of her memory loss. If there's a sudden change and you're seeing symptoms happen or a change in functioning from day to day, it's really important that you call your doctor and let them know that, because things like an infection or even COVID or pneumonia or the flu can actually manifest itself in behavioral changes in the elderly. We know that once there is a diagnosis, most people will live 4 to 8 years, right? And the disease, all these diseases will progress differently in everyone. And the time that it progresses will be different in everyone. We see people who have a progression very quickly from the time they're diagnosed till the time they pass, could be a couple of years. And then we have folks like Ronald Reagan, who lived with a dementia diagnosis, they say, for almost 2 decades. So ways to explain progression. This is a very simplistic way of describing it. We've got the early stage or mild dementia, middle stage or moderate dementia. And very often this is where we start to get those phone calls from family members who are having a difficult time managing those things at home, because it's very often in these stages where they start having toileting issues, showering issues, more increased sleep disturbances, which are making living at home that much more difficult. And then we have or later stage or severe, where the person might lose complete language ability, and even in those very late stages might even be bedbound. We also know that functioning can vary day to day, but even the time of day, the symptoms can vary, right? We hear the phrase sundowning. So very often in the later part of the afternoon, people with dementia can become a little bit more agitated. You know, I don't know about you, but I'm always grabbing my cup of coffee around 3 o'clock in the afternoon. I think our circadian rhythms are just like that. So that time of day tends to be a kind of a tired time of day for people, humans in general. And it also tends to be the time of day that we're on the move, right? From the time we're 5 years old, that 3 o'clock hour comes, we're on the move. We're getting dismissed from school, we're heading home, we're getting things ready for dinner. Those hours in the late afternoon are very a transitional time of the day. And that doesn't go away when we're elderly. And so for folks who have dementia, very often that can be a difficult time of the day for them, that late afternoon. So what are some of the common symptoms that we see with the dementia diagnosis, right? We all know the short-term memory loss, right? But memory loss alone is not dementia. It has to be coincided with some of these other symptoms that you're going to see. Communication difficulties, both expressive language, so their ability to find words, but also receptive language. So you might be giving mom a very clear instruction and she's just not doing it. And you might think, oh, she's being difficult. Well, it's not that she's being difficult. The problem is that she has parts of her brain that aren't communicating with each other anymore, and brain cells that are dying, and it's taking longer for her to process information. So expressive language as well as receptive language. Difficulty performing familiar tasks like getting dressed or bathing, eating, even toileting. Getting lost in familiar places, right? We all know those, we've heard stories about folks who take the car out and get lost in their own neighborhood, or misplacing items. Personality and behavioral changes such as anger, delusions, even paranoia. We hear very often about husbands accusing wives of having affairs after 50 years, or daughters who stole jewelry simply because mom can't find it. Well, mom hid it and then didn't remember where she put it. So these are very common behaviors that we see. Increased physical decline, such as difficulty with walking, incontinence, and eventually swallowing. Changes in sleep patterns, and an increased tendency to wander. We can sometimes think of the progression of Alzheimer's disease almost like an onion, right? And we think about what the outside of the onion is. The outside layers of the onion are things that we've learned recently, right? Our short-term memory, what we had for breakfast, what we had for dinner yesterday, who we spent Christmas with last year. And as we get closer, as we start peeling away the layers of the onion, we start to kind of move back in time. And the center of the onion are those things we learned when we were toddlers, right? How to use the toilet, how to wash our own hair, how to get dressed. So we can think of dementia or even an Alzheimer's diagnosis is almost like a peeling away of the layers of the onion, so that even language ability, all that is on the inside of the onion. And eventually the inside of the onion is peeled away as well. This is what happens. I'm sorry I didn't give you a warning, but we need to look at the brain, because we need to understand that the brain is being affected by Alzheimer's disease. The brain that we're seeing on the left is a healthy brain. The brain that we're seeing on the right is a diseased brain with Alzheimer's. So if somebody had heart disease, we know that the heart is diseased and that's what's causing their symptoms. If somebody has kidney disease, we know that their kidneys are failing. But it's important for us to remember that when somebody has a disease of the brain, this is what's happening to the brain. Mom is not repeating herself or being difficult. She has a disease of the brain that is causing these behaviors and causing these problems. Very, very important for us to get the right diagnosis and treatment. Remember, dementia is not a normal part of aging. Many forms of dementia are due to changes in the brain, but some of the symptoms that we see can be caused by other factors that are reversible. Perhaps your dad started a new medication that's causing some behavioral changes or short-term memory loss, or maybe there's some sort of an infection. So that's really why it's so important to get that early diagnosis, because it can lead to the best quality of life, the best opportunities to plan, and the best support for the family caregiver and for the family in general. And very often the first symptom is the clue to diagnosis. A skilled physician will be able to diagnose based on symptoms and testing. Many primary care doctors are very good at doing the diagnosis, but if you had heart disease, you would go to a heart doctor. If you had a problem with your foot, you would go to a podiatrist. So it's really important that you have a disease of the brain, that you're going to go to either a trained neurologist, psychiatrist, or even a doctor that has that specialty, both specialties, neurology and psychiatry. Medications are just one part of the treatment plan. And I know very often people feel like, they're just going to get some medicine and it's going to help. The problem is there are no medications out there that cure any of these diseases. What a lot of the medications do is help to manage the symptoms so that the person can have the best quality of life, so that their caregiver can have the best quality of life as well. So getting the right support, really important to have conversations early. I know how difficult it is to have aging parents, but it's really important to have those open and honest conversations about what their wishes are to happen if they should get a diagnosis. I said last time we met 3 weeks ago when we had this presentation that nobody ever plans to go to a nursing home. And my mom says, oh, I'm not going to a nursing home. Nobody plans to go to a nursing home, but sometimes it is the best treatment or the best place for them to be based on their needs. The same thing with dementia. Nobody plans to have dementia. Unfortunately, it happens. And it's really important for us to have those conversations early. Find the right doctor and getting the right diagnosis could be very important. Really important to understand the disease progression. So whatever disease you're facing, that you know what to expect, so that when you start seeing symptoms, you know that this is part of the disease process and that you can sort of psychologically adjust to it. Know your care options. So a few weeks ago, we talked about home care options. We talked about senior living options. So I encourage you to go back and watch that webinar that we did back in January to know a little bit more about what your care options are. We are going to cover it a little bit today, but in much more detail we did a few weeks ago. I really encourage you to connect with disease-related organizations. We are very fortunate on Long Island to have an array of organizations like the Long Island Alzheimer's and Dementia Center, the Alzheimer's Disease Resource Center, the Alzheimer's Association, the Stony Brook Center of Excellence. These are all Long Island-based organizations that can support you. They run programs, they run support groups, they provide free counseling, information and referral services, Facebook Live programs for you to do at home. I really highly encourage you. If you would like, you could always send me an email and I could put you directly in touch with my colleagues at these organizations if you need any support or help. Really important, as I mentioned before, to join a support group. You do not have to do this alone. This is not something that you had planned for, caring for your loved one with dementia. So I highly encourage you to join a support group. If you're on this webinar, you can join a support group. Most of them have gone virtual these days. Learn the best practices for managing behaviors and communication. You have to learn, some people sort of have the knack, but you have to learn the skills to be able to communicate with somebody with dementia. And knowing those skills, knowing how to approach somebody, knowing how to communicate with them, even body language can be so important when you're trying to get your loved one to get dressed or take a shower or cooperate with you. So it's really important to sort of learn those skills so that you can have the best experience and be successful in your caregiving. Ask for help. You don't have to do this alone. Very often people want to be helpful. So whether you're asking for help from an organization, from a professional, but even your family members, people sometimes back away a little bit because they're afraid or they don't want to ask the wrong question. But very often people want to be helpful. And so, ask your sister, your brother, your cousin, for help to maybe sit with your loved one for a couple of hours every week. You really don't need to do this alone. And and just remember that you are doing your best. So we're going to talk a little bit about those in-home options. As I mentioned before, we talked about this a few weeks ago, but there are definitely options out there, friendly visits or companion care so that you can take a break, licensed home care agencies if your loved one needs assistance with taking a shower, adult daycare programs. Many of you know I come from the adult daycare world. I'm a huge advocate. Unfortunately, many of the adult daycare programs were closed due to COVID. Some of them have reopened partially, but these are really opportunities for people who are living at home to have a place to go during the day, to engage with other people, to have fun activities to participate in, and to have a sense of purpose and meaning, and for you as the caregiver to get a little bit of a break. Memory cafes. We used to do a whole array of cafes that we held in restaurants. Unfortunately, we had to suspend them due to COVID. We can't wait to get back to them, but those are opportunities for caregivers and care receivers to go out and have dinner in a safe place where other people understands what they're going through. Lots of virtual events these days. Once again, I can help put you in touch with those. Home modifications, you want to make sure that the home is safe. Focus on safety, prevent wandering. Just because your loved one has never wandered doesn't mean that they won't in the future. So it's really super important to look into securing your house so that you can make sure that the person doesn't get lost. And also, if they do, that you're set up with organizations and even the police department to make sure that we can get them home safely if they do. So care in the community or a facility. We all know about assisted living. We talked about it last week. Opportunities for people to be engaged, to be around other people, to be in a safe, secure environment. The person's disease progression might be to the point where they need memory care, a smaller, more structured, more supportive environment where staff are specially trained in communicating and performing activities of daily living with people with dementia. Perhaps the person needs 24-hour skilled nursing care, and maybe a skilled nursing facility is the best option. There certainly are benefits to community living compared to living at home. The structure, the supervision, the socialization, the nutritional needs are met, the engagement, the safety, and of course, the peace of mind for families. And once again, you should watch the presentation from January 19th for more information. The old age home of yesteryear, not what senior living looks like these days. You can see this is actually one of our communities at the Bristol and West Babylon, which is a beautiful space for families to gather. Unfortunately, there are some visitation restrictions these days, but we're hoping now with the vaccine and with the numbers going down that we'll be able to open up to family visitation fully again. And assisted living separate from memory care. So in many assisted living communities, including at the Bristol, there's a smaller community or neighborhood called Reflections, which is specifically designed, even the physical space, for people with memory loss. And there's also freestanding buildings. So for example, our Bristol and Lake Success is our memory care only community. So there definitely are options out there for you, for folks with memory loss. I want to talk about COVID-19 considerations for people with dementia. It could be very difficult to get a diagnosis, right? Because we know that people with dementia might not be able to communicate their symptoms. Maybe they can't communicate their loss of taste and smell. Maybe they can't communicate the tightness in their chest, or because of age, they're not really getting that fever that's sort of typical for older adults to get when they have COVID. We also know that very often people with dementia are not so cooperative with washing hands or mask wearing. So it puts them at an even increased vulnerability. And very often the care that they need makes them more vulnerable. You can't socially distance with somebody when you're helping them in the bathroom, helping them take a shower, helping them get dressed. So social distancing is more difficult. Mask wearing is a little bit more difficult. And plus, very often people, older adults who have a dementia diagnosis, there's comorbidities, maybe a cancer history or heart disease or even lung disease. So those who are most vulnerable, unfortunately, are becoming the most ill. But everything we have done in the senior living world, whether it be adult daycare, home care, assisted living, or even skilled nursing, there have been operational adjustments to help keep people safe. Everything that we do, from dining to recreational activities, family visitation, personal care, housekeeping, every aspect of what we do, it has been affected by the virus. And we continue to be vigilant, and we continue to encourage people, if you have the opportunity to get the vaccine, that both you and your loved one, as long as your doctor says it's okay, should be getting the vaccine. So in summary, super important to get a proper diagnosis, to know what to expect, for you as the family caregiver to get the support that you need, to know what your options are for care out in the community, to have conversations early, to be realistic, and to make sure that safety is your top priority. Another thing to keep in mind is to make sure you have your legal and financial affairs in order as soon as possible. And that's where I will turn it over to the expert, Aaron Futterman.
What a segue, right? Can you hear me okay? All right, I unmuted myself. I must have been making noise. Hello, everyone. Much appreciated, Julie. Thank you as always. And I want to thank everyone that's tuned in. My name's Aaron Futterman, and I think you could, am I pointing the right way? Yeah, you could see my info right there. It's hard to do this with that reverse image thing. I'm going to speak today because we've spoken in the past, although I keep seeing little chat questions regarding home care, and I'll try to touch on that a little bit because I know that that's a area that has got some new changes to the laws. But I was asked to speak about advanced directives and crisis planning. Advanced directives. Now, as far as in my arena, the legal arena, advanced directives are legal documents where my clients have named people to help them with certain activities. And one of the most common ones that we do routinely, I don't care if it's a young couple or a young individual or an older individual, middle age, makes no difference, is a health proxy. Now, the health proxy is the document, creates a principal-agent relationship. The principal, the client, appoints an agent to speak on their behalf regarding health and medical decisions only if for some reason the person couldn't speak for themselves. So sometimes people come in and they feel like, oh my gosh, if I name someone that I'm out of control, you're always the boss of your own health in person. This person, the agent, is only allowed to act or speak for the principal if the principal can't communicate what they would want or what they would not want. Because perhaps they are unconscious, perhaps they were given pain relieving drugs and they're loopy. Then this person, usually it's the spouse, if there is a spouse, can speak for the client. And, now I'll tell you this, and I've been doing this a long time, and I can tell you that I've seen people come in and they go online, they have an attorney that helped them with their, the purchase of their house or some other, got them out of trouble because, whatever, DWI, who knows. But they prepare a health proxy. They say, you know what, I want to appoint my spouse, and then I want to appoint my kids, or can I just put them all as like co-agents? And they prepare this. The fact of the matter is that this happens to be, the health proxy, one of the rare documents in the law in New York State where you can only name one agent at a time. You could have 17 different people, but it's in a pecking order. There's the first person, and if that person is unavailable to speak for you, then it's the second person, and then it's the third person. So, and the reason the law does not permit co-agents is because of the fear that the principal could be on the hospital operating table and the doctor says, look, here's the situation and here are our alternatives as far as treatment. And one person says, mom would want this. And the other one says, no, mom would want that. And, the other one's like, well, I'm not sure. Maybe mom wouldn't want either. And the fact is, the fear is that there's going to be some kind of standoff and no decisions could be made because there's conflict. So it's always one at a time. And for most people that see us, it's usually a married couple. And the person would name their spouse. And then the question, or the harder question, is what if your spouse is unavailable? Who do you name in the alternate? And I always warn people that this is not a pleasant position. This is a thankless position. You're being asked as the agent to make health and decisions for you, for your mom, for your parent, for your grandma, for your sister. And that person can't speak for themselves. It could be a life or death decision. Not fun. So the person that you name not only, has to have the understanding of what you would want, or just as importantly, what you would not want, but have the nerve or the guts to be able to communicate this in a crisis. Not fun. Which of course leads to the second document, advance directive, which is kind of like a sister document to the health proxy. It's a living will, not to be confused with a last will. A living will, and also not to be confused with a DNR. A living will is a statement of what you would want, or the client wants, as far as, or just as importantly, what they would not want if you were ever diagnosed to be in a permanent vegetative state. Most people prepare what we call traditional living wills. And these traditional living wills, and I'm paraphrasing, it reads something like this. It says, to my friends, to my family, to my loved ones, to my attending healthcare physician, if I'm ever diagnosed to be in a permanent vegetative state, there's no brain waves, there's nothing going on upstairs, keep me out of pain, but don't use heroic measures to keep me around. I don't want to be kept alive because there's a feeding tube in my stomach. I'm on machines that help me breathe, where there's no recovery or any meaningful existence beyond this. Now understand, this is what I call a traditional living will. This is your statement. We tailor this to read however you please, but this is really instructions for your agent. Now, this is not a DNR. A DNR can only be signed by the client or the patient and their doctor. And it's usually because they're going to be going under the knife or some procedure or under anesthesia where, there could be some issues. And a DNR, would say, look, if for some reason the heart isn't, started, just don't even bother. I'm 97 years old. I got terribly painful cancer. I don't want to be, revived in these circumstances. Or, sometimes people say, I want to be revived no matter what. The point is that the living will is really instructions for the alternate agent, what to do so that when the extended family comes around and says, look, that's mom, what are you doing? How could you pull the plug? The agent can go, look, I'm just honoring mom's wish. This was mom's wish, and she expressed it to me in this writing, and I'm just being her mouthpiece. She would say this herself if she could. She cannot, and I'm speaking for her. That's the living will. So 2 advance directives. Common. Third one, and this will tie into, crisis planning in a Medicaid context, and that is probably one of the most important legal documents, the power of attorney. The power of attorney is the legal document which again creates a principal-agent relationship, this time not for health decisions, but for management and money and financial maneuvering and manipulating and deciding. The principal can appoint an agent or agents, there can be co-agents, that can help the principal handle their financial affairs if for some reason they cannot. Now, clients sometimes say, well, why might I not be able to? Answer, well, it's possible that, it's a matter of convenience. Maybe something happened and you're hospitalized because, you're having back surgery and something needs to be done at the bank and you can't get there, but they need your signature. Well, as a matter of convenience, your agent can stand in your shoes and sign on your behalf as if you yourself were going to the bank. It could also be that for some reason, unfortunately, you've lost capacity. You're alive, but you're no longer a rational, normal thinking adult. And it could be because of old age or dementia or Alzheimer's, or you fill in the blank, something awful has happened where you're alive, but for some reason unable to handle your affairs. This person would be authorized to help you out and do things on your behalf. Now, when someone is the agent under a power of attorney, that person has fiduciary responsibilities. And I always describe fiduciary responsibilities as the highest level of responsibility in the law, but for a parent to a minor child. Other than a parent to a minor child, the highest level of responsibility one has in the law is a fiduciary responsibility, which means that the agent must behave and act as if they stood in that person's shoes, knowing what that person's wishes and desires are. What would they themselves do if they could go to the bank or speak to the financial advisor, et cetera, et cetera? What would they do? Now, there are many types of powers of attorney, and there are short form powers of attorney, there's durable powers of attorney, there are springing powers of attorney, there's many types. Now, I want to just tell you real quick, what's a springing power of attorney? A springing power of attorney, and sometimes people think, and I can understand why people think this, that the agent doesn't have the power to act. It only springs into effect upon some kind of diagnosis of dementia or incapacity. And people go, yeah, that makes sense. I don't want my kids to have the ability to go to the bank or speak to the financial advisor and do things unless I really, I can't do it for myself. And that I can understand why people would think that this makes sense, but be careful, because when you have a springing power of attorney, the event which triggers it is some kind of diagnosis of incapacity. And we're asking a doctor to declare their patient incapacitated, unable to handle their affairs. And if the doctor understands what's going on, the kids are coming to them saying, listen, Mom, she can't do this, she can't do that. You got to sign these papers declaring her incapable. And the doctor goes, wait a minute, let me understand this. If I sign these papers saying that my patient is incapacitated, unable to, you now can stand in her shoes and go to the bank, take her money, go to the financial advisor, sign the deed. I'm not so quick to do this just yet. And quite frankly, I can understand the doctor being worried. But sometimes we don't have time for doctors to kind of sit on their hands and debate whether it makes sense or whether it's academic or not. Because oftentimes this diagnosis is coming up because someone's going into a nursing home. And, I know Julie touched on it, and, hopefully, we never have to go to the nursing home, but these places, they exist, they're real, and, they get paid. And quite honestly, I always tell people, I don't think that they care one way or the other how they get paid, whether that's through, long-term care insurance or privately paying or Medicaid. Of course, the family would much prefer that Medicaid be available and not have to financially devastate families. But we'll get there in a moment. Back to the powers of attorney. People sometimes get confused with that title, the short form power of attorney. And what that really refers to when it says short form, when you have a power of attorney, it starts with that there's a principal appointing an agent to handle certain duties and certain responsibilities. Like it could be letter A, where you would initial banking transactions or real estate transactions, and there's a whole laundry list of powers. And the reason that it's called a short form power of attorney is that something as simple as real estate transactions. Well, what does that mean? In the statute in New York State, there's actually an interpretation of what does real estate mean? Does it mean buying a house, selling a house, leasing? So when it says short form, it doesn't mean that it's like smaller or tinier. What it's really referring to is that there's an interpretation of each power that's been listed in these documents. So power of attorney is, a powerful document potentially. And when we have our clients sign them, we have them sign a power of attorney that usually includes a statutory gifts rider. Now, I'll tell you recently, and this will be coming up in the not so distant future, summertime, there were some changes in the law regarding power of attorney to try to make it a little easier to enter into and for third parties to honor. Now, when you have a power of attorney, there are several people involved or several entities. There's the principal, right, appointing an agent. And then there's the people that the agent or the institutions that the agent presents it to, like a bank or a financial advisor, right? The bank is being asked to take this piece of paper and now speak to someone other than Mrs. Smith, who they've known for 25 years, and now speak to, the daughter who they never met. And now all of a sudden they've gained access to accounts and checking, accounts and CDs that they never met this daughter in their life. So it has to be executed with certain formalities. And the type of power of attorney that we always discuss and contemplate with our clients permits an agent to make some serious manipulations, and including what's now known, at least right now, as major gifts, like being able to give away assets. And sometimes clients go, why in heaven's name would I sign with you, Aaron, paperwork that would permit my kids or my spouse to get rid of my stuff legally? Why would I ever do this? Answer: the real legitimate reason would be there's some kind of crisis, and maybe we're looking to become eligible to have Medicaid pay the nursing home. And now I've kind of segued into the crisis planning. And the power of attorney is a critical legal document in order to do crisis planning. And the crisis is usually something like this. I get a phone call and it goes, my spouse, my mother, my sister, they're in the hospital, and it's bad news because physically they're well. Their heart is strong, pressure is great, vital signs superior. The problem is my spouse, my ma, they had a stroke and they're not themselves upstairs anymore. They don't recognize me. They don't recognize the grandkids. They can't feed themselves anymore. They can't dress. They need round-the-clock skilled nursing care. And the nursing home is going, how are you paying us? And I hope you don't have familiarity with the costs of the nursing home, but these costs are real, and they can average upwards of 15 to 18,000 a month. And I always say that, just saying that, it just seems like nonsense. It just seems like I'm making the air move by saying this. But when, it's like most things, until it hits someone, it doesn't become real. But think about someone that's been presented with a family member that's not well suddenly. And on top of all the medical diagnoses and all the medical decision making and worries and concerns, on top of all of that, they're being presented with a bill to take care of this person that's 5 figures a month, 15, 16, 17,000 a month. I mean, I kind of joke around, but I remember years ago, I remember when I was an associate, I was doing some planning for a family, and this woman was not well. She was going into the nursing home. The kids had come to my boss, and we were going over things, and they showed me the bill for the nursing home. And this woman, not only did she have normal worries and concerns as someone who lacked capacity, but also she was on a ventilator. So the cost of the nursing home was like $21,000 a month. And I remember, Holy cow. And then this is how Aaron Futterman's mind was working back then. I remember doing a little math, and I did 21,000 divided by 30. I go, oh my gosh, that's 700 a day. And this is what I thought. I'm not making this up. I thought 700 a day. For 700 a day, just throw me in the Waldorf Astoria, and I'll just call up for room service, and the maids will make the bed, and I'll have a nice, view of the park. 700 a day. But these costs are real. I'm not making this up to say that sometimes I've even had higher than that. But the idea with crisis planning is having the right tool, power of attorney, to, oh boy, we need to wrap up. I feel like I haven't even started. I'm getting the high sign here. Okay, real quick. So crisis planning, someone's going into the nursing home, having the power of attorney, critical legal tool in order to do the appropriate planning. So in a crisis, we're looking for Medicaid to pay. I mean, listen, we certainly could, if someone's, Mr. and Mrs. Rockefeller, they could certainly pay $17,000 a month, no worries. But if we want Medicaid to pay, the applicant must pass 3 tests. Number 1, you have to have a need. That presents itself. Number 2, you have to be financially eligible. That means that you could have assets, or the applicant can have assets in their name, no greater than $15,900. Test 3, the 5-year look back. What does this say? This rule says that when you apply for Medicaid, you must submit records for the immediately preceding 5 years. Why? Because Medicaid wants to see if the applicant gave things away in the last 5 years. Why? Because they punish people that give things away, generally speaking. Why? Because if they didn't, everyone could get on Medicaid real easy, right? If someone had problems, worries, and they needed Medicaid, I'd say, all right, no problem. You got the power of attorney? Well, just give it to the kids. They're getting it anyway. And make mom poor, below 15,900 in assets. And next month, they're eligible. Medicaid will punish people that make gifts. What's the punishment? The punishment is a period of time that Medicaid deems someone ineligible. And quite frankly, this year, for every $13,834 an applicant gives away caught in that 5-year look back, that makes them 1 month ineligible. So if someone gives away a house, let's just say it's a $400,000 house, we divide 400,000 by 13,834, that person would be ineligible for about 29 months. So for over 2 years, Medicaid says, don't look to me. Mom gave away an asset worth $400,000. She's deemed ineligible for about 2 years. Family, you figure it out. Come back to us, though, once the penalty is over. So in a crisis, and I wish I had more time because I did get the high sign. In a crisis, if the power of attorney is in place, if there is a healthy spouse, the ill spouse can transfer everything to the healthy spouse today. So long as the ill spouse is made poor, next month, the ill spouse is eligible for Medicaid. And most people go, huh? Aren't they going to see that in the 5 years? I go, that's right. They're going to see it. But transfers, even within the 5 years, to a spouse, that's okay. There's no punishment. But the key is having the right legal tool to sign the deed, because the ill spouse is not signing the deed. The ill spouse is not going to the bank. The ill spouse is not speaking to the financial advisor, transferring the accounts to the healthy spouse. But if you have the right legal tool, you're armed and ready to do so. Then, of course, that brings up the question, well, wait a minute. Now, the healthy spouse, owns everything. Is that a problem? And sometimes this brings up the concept, and maybe people have heard or read about this, called the spousal refusal. And, I usually make a bad joke that, this is what happens to me on Friday nights, that spousal refusal, and all the other guys too, probably. But spousal refusal is really, now that the well spouse owns all of the assets, Medicaid will try to pervert their responsibilities under the domestic relations law to say that the well spouse now has to care for the ill spouse in the nursing home. And by filing a spousal refusal, it's basically a formal legal letter, not even so legal, but a formal letter to Medicaid saying, look, I'm the spouse, I love my wife, I honor my wife, but I'm not paying for her bills. And Medicaid must only determine the application based on the ill spouse's assets. They can't count the well spouse's assets, which now is everything because we've just transferred everything. Now, that brings up the concept of, right, the spousal refusal and excluding the primary residence. If the well spouse has over $130,380 in assets, theoretically, Medicaid could try to sue the well spouse for the assets that exceed that, what they call the community spouse resource allowance. Now that excludes the primary residence. So it gets tricky about planning for now what's in the well spouse's name and planning to make sure that Medicaid doesn't come hammering the well spouse, having made the ill spouse poor to look eligible for Medicaid. Of course, people often ask, well, what happens if, mom is a widow? What do we do then? We don't have a healthy husband to transfer it to. And I wish I had time to explain, but I got to
have you back. Aaron, we need to have you back and here for the full hour. There's so much to learn. It's amazing.
There is a lot, and I'm sorry. And now listen, I'll tell people if they want, they certainly can call, or they're absolutely welcome to call or write or ask any questions, and I'll try to leave some time here. But I will say real briefly.
Share your contact information through the chat as well, so everyone has your contact information and Julie's too. So
I just want to add one last thing, and I apologize that I couldn't touch on everything, but I will say, in the last point I want to make is that with the right power of attorney, even in a crisis, there's no spouse that, at worst, we could save approximately half of an applicant's assets and get Medicaid involved sooner, even in a crisis. But the key is that the person had made that power of attorney while they were of sound mind and understanding. So important, that legal tool to have in place. By the way, sometimes people ask, well, what happens if you don't have a power of attorney? And then we're unfortunately forced to ask a judge through a guardianship hearing to declare that person legally incompetent. Not fun, not inexpensive, and certainly not quick, where it's costing the family, $16,000-17,000 a month at the nursing home. Not fun at all. And I'll leave it off at that. I'm sorry. I wish I had more time.
Don't apologize. This is such important information. I did just share Aaron's contact information in the chat. I think, one of the certain important takeaways is just how important pre-planning is, and that how much value there is in speaking to an attorney that has the expertise to be able to guide you during this time and answer all your questions. But I do just want to take a couple of minutes, because there were some great questions, to just jump on those questions. And Aaron, I'm getting in the feedback here that they want to see more of you. So we're going to have you come back. Sure.
Okay. I don't have a problem with that. I gotta get a better background though. It's very dull, my back, very gray.
Somewhere fabulous. Julie, also people were asking about the previous webinar, and I did share that link on the chat. We'll also share the link to the Schneps Media YouTube channel that everyone will get. And the previous webinar is there, as well as this webinar will be there within 48 hours. So everyone was asking about that. You'll all get that information. We'll also in the email get Julie's contact information, get Aaron's contact information. So if you didn't pull it from the chat, no worries. We're going to give it to you right in your inbox. I'm just going to jump on a couple of questions here because, people are so engaged. Everyone's saying thank you so much. They really appreciate this valuable information that both of you have provided.
Oh, I want to thank everyone's keeping attention, and I appreciate it. Thank you.
Yes, it's such an important topic. So, Julie, Susan has a question for you. Does FTD always show on an MRI scan of the brain? And I know that you're not a doctor, but you're so experienced. And then she wanted to know, if not, is there a better exam that can confirm it?
I'm going to have to defer to the experts on that. I don't feel
Okay.
comfortable. Yeah, I'm not a medical person, but certainly a good question that a good, a physician, a neurologist, or a psychiatrist who is skilled in running the proper tests and deciphering what those tests results look like is a person to ask that question. And I certainly am available to help you find that person if you need it.
It's a good specific question. That's great that you can people can reach out to Julie, and Julie's a great resource for who to ask. But it's important to be asking these questions. And I think, the fact that you brought all of this up, that this is coming to a head, keep getting people thinking about these questions is really critical. Lori wanted to know if a person, this is in your wheelhouse, Julie. If a person is in care at a memory care facility, how do they get the right memory care so they don't continually decline? How does one advocate for their loved one?
So we have to remember that most forms of dementia are progressive, right? So unfortunately, despite the best and well-trained staff and the most well-run community, folks are going to decline. It's unfortunately just a fact of the matter. I'm certainly happy to talk to you, and if you have specific questions about whether or not a memory care neighborhood is appropriate for your loved one, because even on the assisted living side of a community, we certainly have people with memory loss. So there's certainly some factors that we look at to determine which side of the building, if you will, is going to be the more appropriate side for them and the safest side for them. So I'm certainly happy to speak with them, offline and answer that question more specifically.
Terrific. I think as similar as it is to an attorney, speaking with you in one-on-one is important, because every person has a different story, and every person will benefit from different answers and have different questions. So please do reach out to Julie. She's a wonderful, wonderful resource with tremendous information and knowledge. We do have a question that came in, Aaron, when you were talking about the power of attorney.
Mhm.
And Laura wanted to know, does the healthy person have to be a spouse? And then Jeanette said, well, what about one's children? So is there a requirement around who the power of attorney is? I think people wanted a little bit of clarification on that.
Well, when you said the agent under the power of attorney, right, is the document. There's a principal. That's usually the person that's coming to see and says, look, I want to appoint someone. That's the agent. So yeah, the principal has to, have legal capacity. It's a pretty serious thing. You're authorizing someone to handle some very sensitive, delicate things, your finances. The power of attorney that we execute, someone could sign a deed on your behalf. Someone could change the beneficiary of a life insurance policy. That's pretty serious stuff. And obviously the agent has to be an adult, could be any adult, doesn't have to be family necessarily. It could be a friend or a neighbor. I always get worried about the neighbor, when my client is, perhaps a vulnerable person, but it can be any adult. And so long as that person is an adult, that person can be named as the agent in New York State. Unlike the healthcare proxy, where it's always one at a time, there can be co-agents. So, and then the question is, do they have to act together or could they act separately? Now, if you trust these people, you would say, all right, well, I name, my two kids, A and B, and they can act separately because, maybe one is out of state or out of town, and they don't both have to go to the bank and they don't both have to speak to a financial advisor or go to the accountant on my behalf. Either one could. I think that's what they were driving at.
Yes, I think you're right. And I just wanted to have one more question for Julie. And again, this may be really more of a doctor question, but perhaps you can also answer it from the perspective of a living care facility and what you look at. But Michael wanted to know, how can one tell the difference between dementia and natural mental state of aging? My mom is 93, God bless, and in good health otherwise. So are there key things that you note? And I know you talked about some of those, but maybe you can just discuss some of those that would be more of a dementia issue than just a natural mental state of aging.
Well, remember I said that memory loss and dementia is not a normal part of aging, right? So if you are seeing any kind of a cognitive decline, something is causing that. Whether or not the treatment for that, if you will, at 96 years old, you got to weigh sort of the pros and cons of any kind of side effects medication might have, and really whether or not what the person's quality of life is. Maybe they have short-term memory loss and maybe they don't care. Maybe you as the caregiver, you're the one who's annoyed with it, the person repeating themselves and the inability for them to, do activities of daily living on their own. But maybe the person isn't bothered by it. So we always also have to determine who's the one with the problem. So, definitely a conversation you should have with the physician to try to find out what might be causing the decline that you're seeing. And or then determine, whether or not it is something that at 96 years old, requires, medical intervention, and what kind of medical intervention is necessary.
Terrific. Thank you so much. Well, obviously we could stay here all day and take your time.
Yeah, I see some good questions coming in here.
Amazing questions. What I can do is share them with you, and maybe if you wanted to email some of those answers. But also, I really want to encourage everyone to reach out. Reach out to Julie. Reach out to Erin. They're fantastic resources, and they can help you find answers, if not give you the answer. But I think today what we learned so much was that there are fantastic places to go to be able to support you and your loved ones dealing with dementia care and beyond. So I want to thank Julie, Erin, thank you so much for your valuable time. This has been phenomenal. And thank you so much to all of our attendees for joining us. We look forward to seeing you on another webinar soon. Again, you can see the video of the recording of this webinar. It will be on the Schneps Media YouTube channel within 48 hours. The webinar that we did previously with Julie and Erin, that is available on the Schneps Media YouTube channel. We'll provide that link to you in an email tomorrow, as well as providing their contact information again, so that you will be able to have that. And we appreciate your being here. We just wish you to stay healthy, stay safe, and we'll look forward to seeing you on the next Schneps Media webinar. Have a great afternoon, everybody.